Hello everybody, welcome to the Child-Adolescent Sexuality lecture. This lecture is going to be delivered in two parts. The learning objectives are to describe the theoretical foundations for understanding human sexuality, to describe the 8 variables of gender applicable in clinical practice, to identify physiological and psychological sexual development in the child and adolescent, to analyze psychosocial and psychosexual concerns for LGBT teens and their families in practice. We will start our examination of human sexuality at the beginning of life with fertilization of the ovum. The chromosomal distinctions are typically XX or XY, although we know there are other variations. Stages of differentiation include undifferentiated, partially differentiated, and fully developed. At the 7th week following conception, the gonads direct differentiation. At the 7th week, the testes develop. At the 10th to 11th week, the ovaries are developing. TDF, testis determining factor, is present on the Y chromosome. SRY is the sex determining region. That is also at the Y chromosome. The Mullerian ducts are present in both the male and female prior to differentiation. In the males, the ducts degenerate. In the females, they develop into fallopian tubes. Conversely, Wolffian ducts are present in both males and females prior to differentiation, and in females these ducts degenerate, whereas in males the ducts develop into the epididymis, vas deferens, and ejaculatory ducts. This is a chart of sexual differentiation from the genital ridge to the ovary or testes, where on the left the Mullerian ducts develop into the female internal genitalia, and on the testes the Mullerian ducts regress and the genital tubercle and the urogenital sinus lead to the penis and prostate development. Further in sexual differentiation, sex hormones produced from ovaries and testes direct further differentiation of internal and external genital systems. Next, we turn our attention to the 8 variables of gender. The 8 variables of gender have been defined as chromosomal gender, which is XX or XY, the gonadal gender, which is the presence of ovaries or testes, the prenatal hormone gender, which is testosterone and anti-Mullerian hormone for the male, and the absence of these for the female. Prenatal and neonatal brain hormonalization occurs through testosterone and the absence of testosterone in the females, and external genitalia are present in the male and the female sex organs. The pubertal hormonal gender is determined by the estrogen and progesterone in the female and testosterone in the male, and the assigned gender is what the parents and the outside world determines whether it's a boy or a girl. Whereas gender identity is the private internal sense of femaleness or maleness, or gender ideation or gender identity. In early childhood, there is an increase in interest of all kinds, including sexual interest and activity. This is where the child explores their own body and learns about privacy and modesty. By the age of 7, most children know there is a difference among gender, and motivation for learning is primarily curiosity and learning or exploring. Modesty begins to emerge around the ages of 5 to 7 years. Children are often taught at this time not to talk about sex either directly or indirectly by others in the environment. Sexuality becomes more social, holding hands, I'll show you mine if you show me yours, touching or playing doctor, more common among same-gender touching. This is also where children begin to develop the concept of marriage and sometimes role-playing or playing house. In pre-adolescence, from 8 to 12 years old, there is little heterosexual activity occurring during this stage. Children commonly first learn about the notion of intercourse. However, there is homosocial organization of genders into sports teams and so on. It is not uncommon for there to be exploration with same-gender peers. Often, when in this stage, there is an internal awareness of orientation, either heterosexually or homosexually, or bisexually. In pre-adolescence, we have a time of transitions. Freud described this stage as the latency stage, but these are where the first changes begin. Boys may first learn about masturbation from other boys. Girls tend to learn by accident. And in puberty, there is a two-step process recognized. Adrenarche, which begins between the ages of 6 to 8 years, occurs with an increase in androgen secretion, changes in pilosebaceous units, and transient growth spurts. In some children of this age, there is the appearance of axillary and pubic hair, although there is no sexual development per se. This is a chart that shows the influence of gonadotropic releasing hormone. Beginning at approximately the age of 8, the hypothalamus increases its production of gonadotropic releasing hormone. Gonadotropic releasing hormone triggers the anterior pituitary to release luteinizing hormone and follicle stimulating hormone. Luteinizing hormone and follicle stimulating hormone trigger the production of testosterone in the testes and estrogen production in the ovaries. Then comes the effects of sex hormone release, which in the male results in spermatogenesis, and in the female results in secondary sexual characteristics and folliculogenesis. Before puberty, the hypothalamus and pituitary are very sensitive to negative feedback signals from estrogen and testosterone. During puberty, the sensitivity of the hypothalamus and the pituitary to this negative feedback decreases to levels typically seen in adults. This change allows an increase in the production of testosterone and estrogen that stimulates the development of secondary sexual characteristics. The next stage in puberty, therefore, is gonadarchy, where macroneurons of the hypothalamus secrete gonadotropic releasing hormone, as noted in the slide previously, and gonadotropic releasing hormone regulates the release of follicle stimulating hormone and luteinizing hormone by the anterior pituitary gland. This should all be a refresher from your physiology and pathophysiology. In adolescence, from 13 to 19 years old, broadly defined, there is a surge of sexual interest. Testosterone is a factor in both male and female sexual drive, and sharp increase in masturbation to orgasm, and also, for some adolescents, anxiety related to their orientation and a fear of disclosure. This is the end of the first part of this lecture. For the next part, please tune in for the next video.